Okay, so I'm going to talk about a 20-year follow-up of statins in children with familial hypercholesterolemia. My name is Andrea Mercillo. First, my social media. And next we have definition. What is familial hypercholesterolemia? Familial hypercholesterolemia is a common autosomal dominant disorder of lipoprotein metabolism. It is caused by mutations in genes encoding key proteins involved in the low-density lipoprotein LDL receptor endocytic and recycling pathways that lead to decreased cellular uptake of LDL cholesterol. Okay, so next we have applications in medicine. Patients with familial hypercholesterolemia had a greater carotid intima media thickness than their unaffected siblings. After 20 years, the mean thickness was 0.555 millimeters in the patients with familial hypercholesterolemia and 0.551 millimeters in their unaffected siblings.
FH is also called familial hypercholesterolemia, and it is a condition that results from the body's inability to clear high cholesterol from the blood. This results in startlingly high cholesterol levels. So an ideal cholesterol is less than 130 milligrams per deciliter, and in FH patients, generally we see an LDL cholesterol over 190, usually more like 220. And this very high cholesterol level is like a poison to the blood vessels. It results in huge accumulation of fatty deposits and cholesterol deposits in the arteries that feed the heart, and it leads to a much, much greater risk of heart attack or stroke. FH is a genetic condition. It's passed in families, and if one parent has it, then every child has a 50% chance of having FH. If you inherit a bad copy both from the mother and a bad copy from the father, that's called homozygous FH, and it's actually even more serious. If FH has been identified in a family, then every family member should be screened. The key about FH is that you have high cholesterol from the time you're born. So over the course of a life, your blood vessels are exposed to very high levels of cholesterol. And this really takes its toll on the arteries. It affects 1 in 500 people across the world, and it affects everybody about equally. It's estimated that there are 600,000 patients in the United States with FH. FH is diagnosed based on a series of tests, most importantly what your blood cholesterol level is, and then we augment that information with your family history and some physical exam findings that are specific for FH. One of them is called xanthomas, and these are cholesterol deposits that often happen in the tendons of the body, particularly around the elbows or the Achilles tendons. Or there can also be cholesterol deposits around the eyes called xanthelasmas. Based on these three factors, we can diagnose with great accuracy people with FH. Very rarely, but increasingly commonly, we use genetic testing to identify FH patients. The future for FH, I think, is going to be bright because we're going to be able to identify through national screening efforts many more patients with FH and get them on the proper therapy. The other thing is the development of new therapies. And in fact, several new drugs are going to be in front of the FDA in the next 6 months to a year that might potentially be approved that we'll be able to use. Stanford has been a center for FH care for over 30 years. We have the Familial Hypercholesterolemia Clinic where we specialize in the diagnosis and treatment of people with FH. One of the key things that is involved in that is really not just taking care of the individual patient, but also trying to take care of the family members of individual patients. We have a full-time genetic counselor in the clinic, and we have formed the Stanford Center for Inherited Cardiovascular Disease, which is meant to bring an additional layer of expertise onto heart conditions that are genetic in nature. And we're very lucky at Stanford to have some of the best interventional cardiologists, and Stanford for over 50 years has been one of the leading centers for cardiac surgery in the country. The FH is treated very aggressively. We treat patients with FH with medications, principally to lower their cholesterol levels, also with recommendations about diet and exercise. We have lots of patients, particularly young female patients, that have had heart attacks or strokes at an early age, and it's very important to identify those people early so they can start therapy and reduce the risk.
Okay, so next we have pros and cons. Pros: there was no significant difference in smoking habits between the parents who had an event and those who did not. Cons: in the group of 156 parents with familial hypercholesterolemia, 26% had had a cardiovascular event before 40 years of age. The majority had a myocardial infarction, 66%, or angina, which were 17%. The youngest affected parent had a myocardial infarction of 20 years at 20 years of age.
Familial hypercholesterolemia, or FH, is a genetic disorder characterized by greatly increased LDL levels and a family history of premature atherosclerosis. Normally, LDL receptors on liver cells help clear LDL particles from the bloodstream. FH may be caused by any of over 1,000 specific mutations that affect 3 known genes. More than 80% of these mutations increase LDL levels by causing the LDL receptors on hepatocytes to either be functionally altered or underexpressed, decreasing the body's ability to clear LDL from the bloodstream. The result of either scenario is an increased plasma concentration of LDL particles. In addition, impaired LDL uptake also decreases the cholesterol pool in the liver, which stimulates hepatic cholesterol synthesis and the production of VLDL, a precursor lipoprotein to LDL. These defects found in FH can result in an increased concentration of LDL particles starting early in life. Sustained exposure to high LDL levels and increased deposition of cholesterol into the artery walls over time elevate the risk of atherosclerosis and premature cardiovascular disease associated with FH, making early detection of this genetic disorder of critical importance.
Okay, so next we have issues applied in Ecuador. Determining the frequency of dyslipidemia in workers in the healthcare industry city of Quito in the period of November 2015 and January 2016. You can show in the graph number 1 that 48% of workers find their lipoprotein levels normal, while the remaining 52% have some type of dyslipidemia, distributed as follows: 13% hypercholesterolemia, 1% hypercholesterolemia plus HDL hypo, 10% hypertriglycemia, 4% hypertriglycemia plus hypo-HDL, 17% mixed dyslipidemia, 3% mixed dyslipidemia plus hypo-HDL, and finally 5% hypo-HDL. Okay. Next we have conclusions. Of the patients with familial hypercholesterolemia, 79% stated that they were using lipid-lower medication, and 123, which means 85% of those reported that they had taken 80% or more of their prescribed medication in the month before all reassessment. Statin therapy in the group was initiated at a mean of age of 14. Patients who had stopped taking statins did not differ significantly from those who had continued taking them with respect to sex, age, body mass index, or smoking habits.
I'm Dr. Caskey. I'm the Chief Medical Officer for Human Longevity. And Human Longevity is a high-tech company that uses advanced technologies to be able to identify the risk of a disease before the onset of pathology. therefore giving an opportunity to intervene on the disease. Where we've been particularly successful has been in the field of cardiovascular disease, and I would like to illustrate that success by telling you of one of the cases. This was a family in which there was a strong family history of coronary artery disease, early onset, and myocardial infarcts. So our single client that came into the health nucleus, we were able to identify a gene defect in the LDL receptor, a classic gene involved in increased risk for cardiovascular disease. The mutation was unique for that individual. There were 8 other individuals in the family who were first-degree relatives whose risk for the same gene defect is 50%. And we were able to go from the single case on the unique genotype and identify the risk on all those individuals. A very successful example of intervening on the client that came and reaching out to the family and giving them protection. This particular mutation is known to be very responsive to the use of statins. It was the first example of prevention of coronary artery disease.
Okay, so that's it. Thank you for watching.